Good afternoon, one and all. We will start our lecture on dental trauma. I will share the screen now. Traumatic injuries to teeth and supporting structures encompasses one of the most important topics in pediatric dentistry. The International Association of Dental Traumatology says that 1 out of 2 children, that is 50% of the children, suffer dental trauma, and that becomes a huge number. Between 8 to 12 years is the most common age group that suffers dental trauma, and the greatest incidence of dental trauma to primary teeth is between 2 to 3 years. This is basically because at 8 to 12 years, children who participate in a lot of contact sports, and children 2 to 3 years just learn how to, walk. So they are the people, this age group are the most common or most prone to dental trauma to primary as well as permanent teeth. Maxillary central incisors, being the first teeth to be present in the oral cavity, are the most commonly involved, and persons with increased overjet or brookline teeth are more prone, obviously. Etiologic factors can be fights, domestic violence or abuse, falls, road traffic accidents, contact sports, or high velocity trauma. Prevention becomes a very important factor so far as trauma is concerned. The first thing that a pediatric dentist can do is the correction of proclination, that is, in interceptive and preventive orthodontics, we can prevent proclination by correcting habits, by providing appliances which can reduce the proclination of mouth breathers, or taking care of the interceptive and preventive aspects of malocclusion. Mouth guards using contact sports. Many times children who participate in contact sports does not know that there is something called a mouth guard. So you can make mouth guards for children who participate in contact sports. It keeps your teeth safe as well as your temporomandibular joint, which is a growth point, safe. The condyle is kept much lower from the glenoid fossa when you wear a mouth guard. So the condyle, which is a growth point in children, is protected as well along with the teeth. Now coming to the treatment protocol. When a child is brought to the dental operatory for the treatment of dental trauma, there is something preliminary that you need to do before you actually take care of the dental trauma. Record a full medical history by paying particular attention to drug sensitivities and find out if the child is allergic to any medications. You might have to give them antibiotics and anti-inflammatories, so please do check on that. Congenital or acquired cardiac problems, so that you can take necessary precautions to prevent infective endocarditis. Coagulation disorders. If the child has got a bleeding disorder, that needs to be known and that needs to be taken care of. Probably you might need the help of a hematologist. Then diabetes mellitus. Children with diabetes, juvenile diabetes, might have healing issues where diabetic children show delayed wound healing. Determine the tetanus coverage, which is again very important. Find out if the child has long-term immunity, whether the child is covered with anti-tetanus serum. If not, you can give them an anti-tetanus toxoid shot and make sure that tetanus does not happen. And then you have to do the neurological assessment as well. If the child has got neurological trauma, that gets priority and not the dental trauma. So neurological assessment is done by checking whether the child has had loss of consciousness, head or neck pain, amnesia, or other signs of nausea, vomiting, drowsiness, or blood vision, which can be indicative of neurological trauma. If you find that the child has had any of these issues, it is better to refer the child to a neurologic assessment and then take care of the dental trauma. Finally comes the assessment and treatment of dental and orificial trauma. So this is the treatment protocol that we follow for the dental trauma. Now coming to the management of the dental trauma, the first thing we need to do is diagnosis. So what are the diagnostic aids that we have? We can make a radiograph, we can have a transilluminator to project the craze lines, and we can check the vitality with the vitality electric pulse tester. Okay, So radiograph is a mandate in all dental trauma. You have to make sure that the child who comes with a dental trauma undergoes a radiographic evaluation so that all the classifications are right and if you don't miss anything like root fractures and stuff like that. Okay, transillumination reveals a raised line. Sometimes there will not be loss of tooth structure and there will be incomplete cracks on the tooth. So those also can be managed with or identified more. It is better to identify it with transilluminators. But testing usually has to wait for 2 weeks, basically because if the child has had dental trauma, the chances that the pulp is inflamed is very high. So if you immediately do a pulp testing, what happens is the pulp testing becomes, the values becomes very low. In the sense, the small current itself can elicit a response which is, it shows that the pulp is hyperemic. So you will wait for the pulp to settle for a while, like 2 weeks, and make sure that you do the pulp testing after 2 weeks. You will have to compare the values with a normal tooth, and then you have to find out whether the value is less or more. If more current is needed, that means the tooth is progressively going into non-vitality. And if very less current is needed to initiate a response, that means that the tooth is still inflamed or the pulp is still inflamed. So thermal test is more reliable, especially in primary incisors, basically because there can be root resorptions in primary incisors. So cold and hot tests using ice as well as Gutta-percha sticks, not that Gutta-percha cones. The Gutta-percha sticks are more useful. Failure to respond to heat indicates pulp necrosis. Electric pulp testing is often unreliable. So in primary teeth, so you can go for thermal tests in primary teeth. Emergency treatment should be completed and pulp should be left undisturbed for 10 to 15 days before vitality tests. And a darkening of tooth indicates loss of vitality. Darkening of tooth might be because the pulp is bled into the dentinal tubules. The vessels in the pulp has bled into the dentinal tubules and it is gone dead. And the hemosiderin that is gotten into the dentinal tubules is discolored. So emergency treatment should be completed and the pulp should be left undisturbed for healing before vitality tests are done. Factors complicating diagnosis and treatment. It is difficult to diagnose the extent of pulp hyperemia regardless of the amount of tooth structure lost, which means that even if there is no fracture and the tooth apparently looks normal, the chances of tooth going non-vital is high, or the inflammation of pulp cannot be predicted. The extent of pulp inflammation cannot be predicted even if there is no loss of tooth structure. Prognosis of involved tooth again is uncertain in trauma. You have to wait and watch and see how the tooth heals. You know, many times if you see tooth with a closed apex has had a small concussion, you would think that nothing is going to happen, but invariably sometimes the tooth will go into non-vitality and the patient would come back with a discolored tooth or a periapical abscess. Space loss in a developing dentition. Again, that is another factor that complicates diagnosis and management. A child who's very small loses the anteriors because of trauma. There can be loss of space. There can be other complications in formation, and the child can develop habits. Patient cooperation in pediatric patients again is a difficult factor because the child after the trauma would be very, very difficult to treat. He or she might be very upset because of the trauma, and managing them on the dental chair might be a little difficult. Coming to the Ellis classification. Ellis classification is the first classification that we do. Class 1 is a simple fracture of the crown involving little or no dentine, which means that the crown is fractured. There is enamel fracture. There can be a fracture of dentine or there cannot be a fracture of dentine. So loss of simple fracture of crown involving little or no dentine is class 1 according to Ellis. Class 2 is extensive fracture of the crown involving considerable amount of dentine and not exposing the dental pulp. There is fracture. There is considerable amount of enamel fracture as well as dentine fracture, but the pulp is not exposed. Class 3 is extensive fracture of the crown involving considerable amount of dentine and exposing the dental pulp. This is called the complicated crown fracture in Andreessen's classification. I'll come to that later. Class 4 is the traumatized tooth that becomes non-vital with or without loss of tooth structure. There can be loss of tooth structure. There might not be loss of tooth structure, but the tooth progressively has gone non-vital. That is class 4. Remember, it's the traumatized tooth that becomes non-vital with or without loss of tooth structure. That is class 4. Class 5 is total tooth loss or avulsion. Class 6 is fracture of the root with or without loss of tooth structure. There might be loss of crown structure, sorry. There might be a fracture on the crown. There might not be a fracture on the crown, but the root is definitely fractured. That is class 6. Class 7 is the displacement of tooth without fracture of crown or root. It can be intrusion, extrusion, or lateral luxation of the tooth without fracture of the crown or root. Class 8 is fracture of crown and mass. The entire crown is fractured off, and it is called the class 8, fracture of crown and mass. And class 9 is traumatic injuries to primary teeth. That which means all sorts of injuries to primary teeth, not just the fracture, even the luxation injuries are included in class 9. All sorts of traumatic injuries to primary teeth. Class 1. That is what I was talking about. Look at this picture. There is enamel fracture. There might be little or no dentin fracture. It is class 1. Class 2 is there is fracture of enamel as well as dentin, but there is no exposure of pulp. Whereas in class 3, there is fracture of enamel, dentin, and pulp. Class 4 is tooth going non-vital with or without loss of crown structure. Class 5 is complete displacement of tooth or avulsion. Class 6 is root fracture with or without crown fracture. Then class 7 is displacement of the tooth with or without crown fracture, which can be intrusion. In this case, we have shown an intrusion, extrusion, or lateral luxation. Class 8 is crown fracture en masse, and class 9 is traumatic injuries to primary teeth. For you to remember, I am showing this diagram. Next comes the WHO classification. WHO classification shows the fracture of enamel first as the first classification, fracture of crown without pulp involvement, fracture of crown with pulp involvement, that is uncomplicated crown fracture and complicated crown fracture based on Andreessen's classification. First is fracture of enamel, second is fracture of crown without pulp involvement, fracture of crown with pulp involvement, fracture of root, fracture of crown and root, unspecified fracture of the tooth, luxation of the tooth, intrusion or extrusion, avulsion of tooth, other injuries including laceration of soft tissues. So this is the classification given by WHO. Then comes the classification by Andreessen. I would ask you to learn this classification because this is the most comprehensive classification which covers all sorts of trauma to teeth as well as the supporting structure as well as the soft tissues around it. First is the crown infarction. Second one is the uncomplicated crown fracture. Third one is the complicated crown fracture. Fourth one is the uncomplicated crown root fracture. Fifth one is a complicated crown root fracture. I want you to take it down, okay? Root fracture, concussion, subluxation, intrusive luxation, extrusive luxation, lateral luxation, exarticulation. I will come into the details of each of this and tell you what the prognosis is and how you will manage it. Exarticulation, comminution of the alveolar socket, fractures of the facial or lingual alveolar socket wall, fracture of the alveolus with or without involvement of the socket, maxillary and mandibular fracture with or without involvement of the tooth socket, laceration of the gingiva and oral mucosa, contusion of the gingiva and oral mucosa, abrasion of the gingiva and oral mucosa. Now, before we start into this classification and I start explaining all the different types of traumatic injuries explained by Andreessen, I would like to tell you about the reactions of tooth to trauma. Pulp hyperemia. Pulp hyperemia means inflammation of the pulp. Internal hemorrhage. The vessels inside the closed pulp chamber can become inflamed and can break and can bleed into the dentinal tube. roots. Calcific metamorphosis. The pulp is lined by a layer of odontoblasts which can become a layer of mesenchymal cells. Mesenchymal cells which can convert themselves into odontoblasts and can convert or lay calcium deposits which will ward the pulp off from injury. It's called calcific metamorphosis, the change of pulp into a hard substance which is similar to dentin. Internal resorption, that is odontoclasts or osteoclasts are cells which eat away bone and teeth. So odontoclasts, these cells can differentiate into odontoclasts and cause resorption from inside, which is called the internal resorption. Peripheral root resorption. Resorption of the stem cells on the peroneal ligament and the root surface can convert themselves into osteoclasts and odontoclasts, which can eat away the root from externally. This is called the peripheral root resorption. Necrosis of the pulp, tooth ankylosis, that is death of the pulp, and ankylosis where the peroneal ligament will fuse to the alveolus and there will not be any space for the peroneal ligament, or in the radiograph you will not see the peroneal space. These are the reactions of tooth to trauma, and I will tell you how it occurs. Sequelae of trauma to primary tooth. What happens when the primary tooth gets traumatized? Hypomineralization of hypoplasia due to trauma, infection, or both, which is called the Turner's tooth. So, as you all know, the relationship of the permanent tooth bud to the primary tooth root is that it is immediate. It stays immediately behind the root tip of the primary incisors. So, when there is a trauma, especially an intrusion, it might go and touch the tooth bud which is developing inside, the permanent incisor tooth bud which is developing inside, which is behind the root of the primary tooth. And this can lead to hypomineralization or hypoplasia if the development of enamel or the dentin is happening. Hypoplasia due to trauma, infection. The periapical infection of the primary teeth also can lead to Turner's tooth. Dilaceration. When the tooth bud is disturbed and it is slightly, disturbed or dislocated from its position, the root development happens in one direction and the crown development happens in another direction, leading to a bend in the root formation, which is called the dilaceration. Formation of reparative dentin. That is to prevent the infection from happening. The pulp wards off the infection by forming odontoblasts, which lay a layer of dentin which tries to protect the pulp. Sequelae of chronic infection like loss of tooth bud or periapical abscess or loss of vitality, etc. also can happen. Now we will come into the details of each. We will talk about crown infarction. What is crown infarction? Definition is incomplete fracture or crack of the enamel without loss of tooth structure. Diagnosis is normal gross anatomic and radiographic appearance. There is no loss of tooth structure, there is only a crack. So the tooth appears normal and there is no radiographic changes basically. Crazed lines, this is where you can use your transilluminator. Crazed lines are apparent, especially with transillumination. Treatment objective is to maintain the structural integrity of the tooth and pulp vitality. If the tooth has got an open apex, the chance of tooth going non-vital is very less because the neurovascular bundle is quite thick and the tooth will not, the neurovascular bundle will not get severed at the apex of the tooth. General prognosis, the complications in such situations are usually unusual, but if the tooth has got a completely developed wound, the chances that the neurovascular bundle is fractured off or severed off is quite possible. So you will have to do a pulp vitality test after 2 weeks and make sure that the tooth is vital. Crown fracture uncomplicated. The definition goes like this: an enamel fracture or an enamel dentin fracture that does not involve pulp. There is no pulp involvement. Diagnosis is clinical or radiographic findings reveal a loss of tooth structure confined to enamel or to both enamel and dentin. Treatment objective is to maintain the pulp vitality and restore normal aesthetics and function. You can do a fragment reattachment by reattaching the broken fragment if the patient is able to bring you that, or else build it up with composite. and protect the exposed dentin as early as possible. If needed, you can, if the considerable amount of dentin is exposed, you can use a sandwich technique by using glass enema cement as a sandwich between the composite and the tooth and restore normal aesthetics and function immediately. You should check for the fragment which is lost, which can get embedded in the injured lips, tongues, or gingiva. For small fractures, rough margins and edges should be smoothed off. And for larger fractures, the lost tooth structure can be restored. General prognosis is good. The prognosis of uncomplicated crown fracture basically depends on the concomitant injury to the peroneal ligament, that is, if it is associated with a luxation injury as well, and secondarily upon the extent of dentin that is exposed. If there is considerable amount of dentin is exposed and the patient does not report to you immediately, the dentinal tubules can transmit heat, cold, and bacteria into the pulp chamber and can result in pulp necrosis. Whereas if the patient reports to you immediately after trauma, the chances that the tooth goes non-vital is very less, because we can immediately cap the or do an indirect pulp capping and do a restoration. Optimal results follow immediate assessment and care. So now, before going into complicated crown fracture, I would like to stop this class. Please get back to me after doing a good reading. I want you to go back and read about all these things which I have told you. And if there is any confusion or any doubts, please feel free to contact me. Thank you.